have no relevant disclosures. This is a very old case. You can tell that from the title. I used to think this was the most unlucky man in the history of the world, but I've come to conclude that all of the problems were not pure luck. He was 56 years old. He had a job as a roof repairman in Houston, Texas. And sure enough, he fell off a roof and broke his back, wound up having back surgery at the Houston VA, and of course he got post-op DVT. At that time, some of you older folks might recall, we used to treat DVT with heparin for a week or two before we even started warfarin. And the reason we did that was that we didn't know any better. But this man, on day 7 of heparin, got worse. His leg became more swollen, he became short of breath, he coughed up blood, he was transferred to the medicine service. Actually, the one stroke of good luck he may have had was he was put under the care of a brilliant, handsome resident, myself, and was found to have new pulmonary emboli, and his platelet count was 40,000. So in 1976, the heparin-induced thrombocytopenia syndrome was first being described. And in fact, in that year, there were major papers in the Annals of Internal Medicine and New England Journal on this phenomenon. And I read my journals. I said, my gosh, this is that HIT I've been reading about. I even got our lab to mix his platelets with heparin and this and that. I think it was the first positive heparin antibody test in the Texas Medical Center. So we stopped the heparin. We put in an IVC filter. After all, back then, what else could you do? We gave him a bunch of warfarin. It seemed like a good idea at the time, and back then, what else could you do? And on day 4 of warfarin, he developed a necrotic lesion of his thigh. At that time, his pro time was 25 seconds. What his INR was, I can't tell you because the concept hadn't been invented yet, but it was probably about 3.5. I actually got a picture of his thigh. So this is Coumadin-induced skin necrosis. So I said, my gosh, he fell off a roof, DVT, heparin-induced thrombocytopenia, and warfarin-induced skin necrosis too. I mean, what are the odds on that? So we understand today that this was no coincidence. We understand today that HIT is an extreme hypercoagulable state characterized by all sorts of arterial and venous thromboemboli. I have published data that IVC filters are an extremely bad idea in HIT. We know that warfarin use unopposed early at excessive dose precipitates worse clotting or skin necrosis in these patients. This man actually became septic from that lesion and died. And believe it or not, I actually published that case. That was the first case of HIT I ever saw. I actually published his case 25 years later as part of a series of 8 cases of patients who got Coumadin-induced skin necrosis with the background of HIT. This was one of our other cases. And like Ken's presentation, mine is going to be very case-based because telling stories is what I do best. And in contrast, I'd like to tell you about this woman that I saw 15 years ago. She was 30 years old. She had a history of diabetes insipidus, and at a suburban Houston hospital, they had diagnosed her with a pituitary tumor. But she developed other signs and symptoms, and it became evident that what she really had was Langerhans cell histiocytosis. So her physicians decided to treat her with 2-chlorodeoxyadenosine by a 7-day IV infusion as an outpatient. They placed a portacath, and each day she came to their clinic, and they hooked her up to a battery-powered infusion pump. And each day when they did that, they did something that I can absolutely assure you was totally unnecessary, and that is they flushed her catheter with heparin. No reason to do that. 2 days after the chemotherapy had finished, she presented to their emergency room with severe pleuritic chest pain and shortness of breath. And her physicians had no idea why she was having such severe chest pain. The fact that her platelets had fallen, this is a known side effect of 2-CDA, although the count fell quicker and sooner than we usually see, They admitted her to the hospital. They started her on a morphine PCA pump. And the notes in the chart indicate that someone said, well, maybe she has histiocytic involvement of her lungs. Let's do a chest CT. Histiocytic involvement of the lungs 2 days after finishing chemotherapy doesn't sound like a likely proposition. But nevertheless, they were very surprised to find major bilateral pulmonary emboli, but at the same time, her right arm became extremely swollen and painful. This is where the portacath was. Doppler confirmed extensive venous thrombosis in that arm, so the portacath was pulled. Therapeutic doses of low molecular weight heparin were given, which dropped her platelet count over a few hours to 19,000. Her arm became more swollen, her other arm became swollen, chest pain, oxygenation were worse, her face became swollen, she complained of headache. What was going on? So she had SVC thrombosis on top of everything else. And of course, it was midnight Sunday when I was paged by a hematologist oncologist at an outlying hospital. He said, Larry, listen, I have this young woman clotting everywhere. I have no idea what to do. I need to transfer her to your hospital immediately, midnight Sunday. And he starts telling me about the case. I said, oh, HIT, why didn't you just say so? And he said, well, no. And I said, look, just send the lady. And she arrived at 3 a.m. with heparin dripping in her arm. The imaging not only showed extensive bilateral pulmonary emboli and extensive venous thrombosis of her extremities and the SVC syndrome I told you about, but she also had a major clot obstructing the right pulmonary artery. We were very concerned about whether this woman was going to survive. So what would you do at 3 a.m. Monday morning? We stopped the heparin. We ordered a heparin antibody test. We started argatroban, which had just come on the market. Although we had some experience with argatroban, having participated in the clinical trials. And her heparin antibody eventually came back extremely strongly positive. And of course, it's always better to be lucky than good, because over a week or so, all her signs and symptoms resolved. Her platelet count came up to normal. She was transitioned to warfarin. She took warfarin for several months. She has never had another problem with blood clots. She stays in touch with me. She moved to San Diego. A year or two, she called me to let me know that her histiocytosis had relapsed again. She was being started on a new medication. But again, she never had any other problems with blood clots. So more than a couple of lessons we can take away from these first couple of cases is, that HIT does happen, that it's always a potential catastrophe. The first case showed you about the dangers of warfarin, which we probably won't have time to go into much more. The second case, the only heparin exposure she had was from flushes to her catheter. That's all it takes. And we've published a number of such cases. Low molecular weight heparins cause HIT 1/10 as often as unfractionated heparin. But once you have HIT, the antibodies virtually always cross-react, and low molecular weight heparin is strongly contraindicated in HIT. I think you'll agree with me that the prevailing lack of awareness that existed just a few years ago, and to a smaller extent today, contributes to putting many of these patients into life-threatening situations. And I've begun to show you that some of our new treatments and strategies are improving outcomes for these patients. So HIT is and has been for quite a long time on the top 4 list of diseases people should know a lot more about than they do. And why all of these tests are hematologic problems is something I've never figured out. So if any of you have insights into that, please let me know later. And part of the problem is that there are so many paradoxes that surround HIT. These are just some of them that has interfered with getting the message out. That the most powerful anticoagulant of the 20th century which has saved uncountable lives and limbs, also can produce the most extreme hypercoagulable disorder that we know of. And every year, people continue to lose lives and limbs to this problem. An immune reaction to an anticoagulant, which lowers the platelet count, virtually never causes any bleeding, but rather causes this extreme hypercoagulable state. And one would think that doctors and nurses and pharmacists would be extremely knowledgeable about this because it's common, catastrophic, preventable, treatable, and it's something that we do to our patients. It's also a major source of litigation. Yet, at least until recently, medical curricula, medical textbooks paid almost no attention to the problem. This has improved some, which leads to another paradox that we are going to spend a minute or two on in just a little while, that finally, as awareness is increasing, we actually have a problem with overdiagnosis, and that can also cause harm to patients, a point that I'm going to come back to, a point that I didn't used to have to go into just a few years ago when I gave this same type of talk. There's an obligatory slide about pathophysiology, which I'll go through very quickly. So the blue squiggles are heparin, and when you give it to your patient, it binds to platelet factor 4, which are those purple doodads that live in platelet alpha granules. And some people will recognize the modified platelet factor 4 as a new antigen. The immune complexes bind to platelet Fc receptors and coat the surface in platelets in such a way that there's intense platelet activation. So that causes more PF4 release and gets a vicious cycle going. It also causes microparticle release, which is intensely thromboplastic, leads to thrombin generation. These antibodies that are formed also bind to glycosaminoglycans on endothelial cells, causing endothelial activation and injury. So the reason these people clot is the thrombin generation, the platelet activation, and the endothelial injury. So this is a clinico-pathologic syndrome. Platelets fall in 95% of patients. They're going to fall by more than 50%. This occurs 5 to 12 days after beginning exposure to heparin. Timing is crucial. And there is an extreme risk for thromboemboli up to about 75%. In making the diagnosis, you eventually want to confirm the presence of antibodies with a serologic test. And I've already mentioned the complications, including high mortality. The degree of thrombocytopenia in HIT is usually moderate. And you can see that the median platelet count's about 60,000. One thing you might notice is about 10% of people, the platelet count is not below the normal range, but these people with 200,000 platelets are people that had 600, 800,000 platelets a week earlier before they were exposed to heparin. In another 10% or so of patients, the platelet count is extremely low, 10, 15,000. These people have been shown to have the very highest risk of blood clots. So these very low platelet counts are by no means a contraindication to effective alternative anticoagulation. In fact, it's a strong indication for anticoagulant therapy. The 4T clinical probability test has become popular, and appropriately so, and this is a tool that can help you judge clinically the likelihood that your patient has HIT. And you award 0 to 2 points as to whether the fall in platelet count is typical, whether the timing is consistent with HIT, whether concomitant clots have arisen at the time that the platelets fell, and whether there are other good explanations for why the platelet count is low or not. And based on this, you can divide people up into whether the likelihood of HIT is low, moderate, or high. And in a slide or two, I'm going to show you that when the likelihood is low, the chance of having HIT in a couple of meta-analyses is less than 0.5%. If the likelihood is low, you don't need to be ordering any antibody tests. You don't need to start heparin. If the likelihood is moderate or high, you ought to start an alternative anticoagulant while you wait for serologic confirmation of the diagnosis. So I know you can't read this, but this is one meta-analysis showing that in people with low pretest probability based on 4 Ts, the likelihood of HIT is extremely low, down around 1% or less. High probability tests, about half the time they might have HIT. You need to act and wait for serologic confirmation. And I certainly don't have time to go into detail about the serologic tests, but we do need to make some mention of the fact that widely used are the ELISA antigen assays because they're simple, reproducible, widely available, quickly available, and they can be extremely helpful, but you have to know how to interpret them. And if your lab says the test is positive, there should be a long pause and you tell them that you have no idea what that means and you need to know the number. You need to know the optical density. Positive doesn't mean anything. Functional assays are much more specific. The serotonin release assay is the most widely used. It's certainly not perfect, and it's rarely available in real time. There are technical problems. There are problems with reproducibility from lab to lab. But in a difficult case, you probably do want to get an SRA test for confirmation. And again, this slide is not meant to be read or memorized, but the point I want to make from this test is there's data on thousands of patients. This is from 1,002 patients published 6 years ago by Ted Workington, where they found that if the ELISA test was less than 0.4, nobody had positive platelet activating antibodies, nobody had HIT, so the lab will tell you this is negative. But the problem is that currently the labs are telling people that 0.4 to 1.0 is also positive. Turns out that 0 to 3% of those people might actually have HIT. 97% or more do not have HIT. And only when your OD is very high, above 2, is there a 90% likelihood of HIT. So you need to know how to interpret the ELISA test. And if the lab tells you positive, doesn't mean a thing. A problem that has arisen, well, I've already mentioned overdiagnosis, and we're going to go into that some more. But a major problem is that this test is being ordered willy-nilly on everybody who hits the door, whether their platelets are low or not. There's been a number of publications showing that. This is a study we did at my own hospital. We looked at 131 consecutively ordered heparin antibody tests in our ICUs. We found that 110 of these people had a low probability score, and of course none of them had HIT. Actually, when I survey major hospitals and also reference laboratories, 2% or less of samples that they get actually have platelet activating antibodies when samples are sent to reference laboratories for that test. In our study, 28% of people, after searching their chart, had no evidence of ever having received any drop of heparin, and only 2 people had a high pretest probability, and these were 2 of the 3 people who wound up having HIT. So the irony is that as awareness and concern for HIT are peaking, the disorder is actually becoming less common. We're using more low molecular weight heparin than unfractionated heparin. A major reason for decreasing overall incidence of HIT is that heart surgery has declined dramatically in this country and all over the world. So why do we have this overdiagnosis epidemic? Because people are becoming more aware. They know this disease can be deadly. They don't want to miss it. They know there are medical legal ramifications. The clinical scoring is extremely good at ruling out HIT, but I told you that even with high probability clinical scoring, you have HIT only half the time. We've talked about false positive antibody tests and the fact that people need to know how to interpret the test, not call it positive or negative. And another reason for the overdiagnosis is that physicians don't realize the negative implications that accompany branding a patient with a diagnosis of HIT. And these are some of them. There's several studies that show that if you even just think about whether your patient has HIT, you've run up his bill several $1,000s right away. These people get anticoagulated with drugs that are sometimes tricky, especially when used by people who are unfamiliar with them. There's a learning curve. I've seen surgeries and transplants delayed or canceled, people culled from transplant lists, people denied access to outpatient dialysis facilities. Dialysis centers are paid by capitation. They don't want to accept anybody who's getting an argatroban infusion. They lose money. And they get branded on their chart HIT. Many of these people have never had it and shouldn't be branded as such. I remember this man vividly. This was a case from 1997. He had heart problems, he had heart surgery, he had some complications. His platelet count was normal, but on day 7 it fell to 66,000. And his cardiovascular surgeon wrote 3 orders on the chart. It said, stop every drop of heparin, send a heparin antibody test, consult Dr. Rice Hematology. Do you think that the reason the cardiovascular surgeon was so astute is because of all the talks I've been given all over my medical center starting in 1979? Do you think that's why he was so astute? He'd never heard me talk on HIT. He'd been sued. And we have a lot of heart surgeons in my medical center, and finding 1 or 2 who have not had an HIT lawsuit or more than one, is difficult. I've tried. When I saw this man, I actually believed he did have HIT because he was a very unusual patient. He was afebrile, he wasn't on an H2 blocker, he wasn't on vancomycin, he didn't have a balloon pump. It didn't look like there was any other explanation for why his platelets were low. My friend Ted Workington had just published a paper. It said that if you have somebody with isolated HIT, that means the platelets fall, they have the antibodies, they have HIT, but they have no new clots. He said you need to anticoagulate your patient because if you don't, there's a 50% chance that they're going to get HIT. Usually in the next week, they're going to get a clot. I had read the paper. I wasn't sure I believed it. I talked to Ted about it. I talked to my friends about it. I said, we're not going to anticoagulate this man who's post-op unless we really need to. We did Dopplers, arterial and venous, of all his extremities. There were no clots, so we just stopped the heparin. He got better. He got extubated. His platelets went up. I wrote a sign-off note, benign recovery from isolated HIT. An hour later, he had a lethal arrhythmia and died. I'm sure that he clotted his bypass grafts, a well-known complication of HIT. I'm quite sure that he's the last patient with isolated HIT I will ever see that doesn't get anticoagulated. Ted studied every confirmed case of HIT in Hamilton, Ontario over a 14-year period, and he found that these people with isolated HIT, after you stop the heparin, 53% got a new clot. 5% of his cases presented just the way my man did, with acute sudden death. So you can't just stop heparin, you have to anticoagulate these people. So I'm quickly running out of time, which means you guys don't get to hear some very good stories. There's typical HIT we've been talking about. Rapid onset can occur immediately if someone's had recent heparin and been sensitized. We're seeing more and more delayed onset HIT. People develop clots, come back to the hospital after they've been off heparin for several days. So you can't just stop heparin. You can't use low molecular weight heparin or begin warfarin early. You do have to initiate an alternative anticoagulant. And for my last slide, I will tell you that what we use to treat HIT is argatroban, the only FDA-approved treatment for HIT, but most of our patients are receiving bivalirudin or fondaparinux. Thank you for your attention.
Great. So questions for Dr. Wright?